Hey guys, Don here. Welcome to Podiatry Practice Mastery, where I'm helping you get your practice to the $1 million mark and beyond. Today I want to go over kind of some of the treatments that we've been doing in the office. These are the things that we do daily, and I just want to let everyone know that I'm going to start reducing, I think, the amount of episodes that I'm doing. I'd like to develop, I guess, better episodes and maybe less frequent because I was talking to some of the other doctors, and I feel like putting out, like, let's say a 20-minute or 15-minute podcast once a day, that adds up to be about an hour a week of content. And I think a lot of people have a hard time listening to that much content unless you're like driving every single day to work. And I also feel like sometimes it's getting to be a little bit repetitive in terms of the patients that I'm seeing and kind of going over in my practice. And so I just kind of letting everyone know. So if I kind of ghost everyone a little bit, that's kind of the issue. Okay, so let's go into this. So this is I skipped the other day, so I have 2 days here. The first was finishing up for my Friday. I had a patient. This is the first patient I've ever done this for. They had IPKs, multiple of them, on the feet, and they're really, really painful. And I did Swift for this patient. Now, in the Swift literature, they talk about you can use it for IPKs. This patient just had multiple of them. He's just been in a lot of pain. We've tried to trim them down in the past, and there could be, I think the idea behind the Swift is that there could be like a verrucous base to it, and that's why it works. So this is my first patient I've done these IPKs. I haven't done a lot of IPKs. I'd love to know if other people have had good success with that. I just find that they tend to be a big struggle, especially if they're really painful. Okay. Next patient was there's a Cariflex patient that had to come in. I've had a couple of lately these Cariflexes that I take off and they have a green nail underneath it, and they're kind of worried about the Pseudomonas infection underneath the nail. Or sometimes it can be blood. Sometimes if you only have a little bit of nail to attach to, it can pull off and there can be a little bleeding underneath there. But this patient, I put an Anifix on the nail to help it to kind of grow a little bit more normal. So that's what I did for that patient. Next patient was a bilateral Cariflex. She got the kit. She also wanted to do Lamisil, and then my kit for the Lamisil. So this is something that I find been working really well. If there's a good book out there recently, if you haven't heard about it, it's Money Models, and he talks a lot about having an offer and then having different types of upsells and then downsells. And I think this is something that works quite well with a lot of the things that we do. And I find really the easiest way to explain this, and probably to get other doctors, if you have other doctors maybe that aren't using the same protocols, just to put it on a treatment sheet. I'm finding that tends to be the easiest way for me to explain things to patients and have them think through the recommendations. Next patient was a 78-year-old female. She had a right third toe kind of a rubbing callus, and I recommended she have an exostectomy if it doesn't get better in the future. That's one of my favorite procedures, just a little rasp that we do right here in the office, and we numb it up. Next patient was an IPJ hallux ulcer that's healed, and now it's really just a callus on that area, so I recommended they get Cara 42, which is a urea cream for the callus, and then just a Marigel Blue, just a lotion for the lower legs. Next was a 48-year-old female. She had a right wart. We did lesion destruction today, and she's going to set up 4 sessions of Swift. So this is her first visit. We did just to make it a little bit softer because it was hurting her, I trimmed it down and I put salicylic acid. Now I know the salicylic isn't going to work long term, but she is going to be coming back for that Swift treatment, number 1 out of 4. And I do those once a month. And even on my consent, someone asked me for my consent the other day, so if you want to just shoot me an email, don@podiatrypracticemastery.com. And this consent it actually has the consent for the Swift, and then it has a place where they can put in the 4 dates for their 4 treatments, so it has everything kind of scheduled out on that one consent. Next patient, 29-year-old man for an IND, for an ingrown toenail. The next was a 40-year-old man. He had a left heel injection, and he had warts, both on the left foot. And I'm not sure if the heel pain was from plantar fasciitis or his equinus that he had, or was it due to the painful wart? So I did the wart treatment, I did the cortisone. He was feeling better, and I'm going to see him back in about 3 weeks for the cantharidin treatment, and then seeing how his heel pain is as well, and possibly. Actually, I think I did an ultrasound as well, and I didn't know on the I didn't see on the ultrasound that there was a lot of thickness to the fascia, so it made me think it's more due to his tightness or his equinus. Next was a 75-year-old female that had left second toe pain. She had an interesting thing. In the past, she had a first MPJ fusion, and because of that, it was slightly up, and she was overloading the second toe. So I talked to her about doing an orthotic. She's going to come back if she wants that, but at least she understands the mechanics of it now. Next was a 78-year-old female for a left matrix follow-up. She's doing better. As a reminder for my matrices, I only do one follow-up at 3 weeks, and I do a 10-minute slot. And then she also has a kind of a pincer nail, and so I talked to her about doing an Anifix in the future to help with that, to help bring out the edges of that toenail. Next was a right foot sprain. She had pain more to like the fourth tarsal metatarsal joint region there, and she also had some left Achilles pain, and she really didn't want any treatment, so I think she just wanted to kind of appease her husband who told her to come. Next was a 61-year-old female. We did an Anifix because it fell off, so I just did an office visit for that, and that was something that, that's a lower office visit, so to bring that up, I've told my staff that, like when Anifix falls off, to put that in like a 10-minute slot, because it doesn't really take that long. Next was a left, she had there was just a nail care patient that had a nail sample because she wanted nail fungus treatment, so 65-year-old female. That was the morning. Afternoon was a left nail sample, and she was also status post Anifix, and she's been doing well with the Anifix, so we're going to leave that on until it falls off. Next was a 56-year-old for a Lamisil booster, which is the second visit for Lamisil where I give them another round of it. Next was a 80-year-old female that had some lateral foot pain. Wasn't really that bad. I don't really find that many 80-year-olds with plantar fasciitis. She thought it was, but it wasn't. I'm going to see her back as needed. Next was a nail issue that we debrided them. Next was a 15-year-old had, this is the one that has the bursal sac posterior to the Achilles, and it's quite painful. This is a girl that kind of gets it inflamed when she's swimming, and so this is number 4 out of 6 for shockwave. Next was a 42-year-old female for right posterior tibial tendonitis, number 2 out of 6 for shockwave. Next was a 17-year-old female for a left ganglion. I did an aspiration with ultrasound, and she's going to do Coban daily for a couple weeks, so hope it doesn't refill up. And then the next patient was a 45-year-old for left plantar fasciitis, number 4 out of 6. So that was my Friday, and then kind of coming back to the Tuesday, which was yesterday. I'm sorry. I'm getting the days messed up here. Tuesday, which was yesterday, there was a 71-year-old female that had some foot pain, some matrices, INDs. So as I'm saying, I think these are getting a little bit repetitive. I'm trying to think see if there's anything really, really good here. I did 2 patients that had equinus bilaterally. So they got bilateral night splints and the foam rolling in the morning stretch. And what makes them really a believer is doing the roller ball on the back of the calf. So if you don't have some type of a dynamic demonstration for patients, I really think that helps a lot. I just bring this, it's called an orb ball in the room, and I roll it on the back of the calf, and it really helps them for that. So they can kind of recognize the importance. And then when I offer it, I say, you can do 3 hours on the right and then 3 on the left, which is like 6 hours, or you can get bilateral night splints, and they many times prefer to do the bilateral night splints. So there's some other shock waves and some other types of treatments. So anyway, just kind of letting you know, I've been doing this format for a long time, and I'm going to try to spice it up. I'd like to make more valuable content. So let's say one really, really good one once a week for the podcast versus multiple ones. And I've thought, just kind of talking you through this, then I could repurpose some of those as well, like the email newsletter and things like that. to help give more value, because I think it gets a little bit repetitive. I do have a number of listeners, but I'd like to get more listeners, and hopefully by doing that method, it'll work a little bit better. Okay, guys, thank you. And once again, any questions, shoot me an email, or if you that's the best way, and then it gives you more fodder for these podcasts. Okay, have a great day.